Okay, so we are going live in 3, 1. Please start. We are live.
So, very good evening, all the doctors. Very warm welcome on behalf of Aries to today's session of Crevast Academy. As all of you are aware, at Aries, we believe in improving health outcomes. Aries, we are very proud to share with all of you that we are #1 company in terms of patient care. So various patient care initiatives which we carry out, they symbolize the ethos of Aries, which is power of empathy, truth of science. So Crevast Academy is a round-the-year event wherein the contents are curated to disseminate and master the nuances in clinical management for improving CV outcomes. Crevast Academy is guiding various clinicians across India to improve the cardiovascular health among patients. So these are few glimpses from the earlier sessions of Crevast Academy. The first session was on statins essential for diabetic heart. The second session was on statin optimization need of the hour. Session 3, the battle against arterial plaque with statins. Session 4, the jury on statin-associated muscle syndromes. And today we have gathered here for the 5th session of Crevast Academy, which is on the hidden threat, low LDL, yet high CV risk. And today's moderator of the session is none other than Dr. Sanjeev Shah, who is Senior Diabetologist and Endocrinologist at Nanavati Meg Super Speciality Hospital, Mumbai. He has more than 40 years of clinical experience, and he is associated with Clinical Pharmacology KEM Hospital for more than 5 years, and he has been the researcher in the global trials in diabetes for more than 20 years. More than 50 original research papers and 20 book chapters have been published by him in various national and international journals. So with this, I would like to hand over the session to Dr. Sanjeev Shah. Sir, hand over, requesting you to take it from here. Dr. Sanjeev Shah, sir.
Yeah, my slide is visible. Khushbu, my slide is visible.
Yes.
In full screen format.
Yes.
Thank you, Khushbu. It's my pleasure to be part of this 5th Crevast Academy. In all the meetings, we have made an attempt to pick up select recent publications which are clinically relevant to large number of internal medicine practitioners across the country. In most of the programs, we had listeners to the range of more than 1,000 people. So I'm happy to be with 3 experts today, and we have kept talks in a shorter format, but we have a more interactive discussion. And I want each one of you to participate, whether you are talking or listening to other experts. To set the stage, the first and important topic this time is primary prevention. Most of our past topics had been secondary prevention. So the question arises when we look at the patients or people in population who gets vascular disease. It's believed that it's an aging phenomena, but we do not understand it starts at what age. Only 25% contribution comes from genetic susceptibility in relation to all aging-related disease. So there has to be a risk factor to have vascular aging. And so each risk factor in each individual would have a different contribution. And the combination of multiple risk factors may make things worse. We understand vascular disease, coronary artery disease, and relate far more with dyslipidemia and abnormal lipid level. So how much a hypertension contributes alone, or how much a diabetes contributes, is all well known. Some people may not know and how much in dyslipidemia LDL will contribute. When I talk about an vascular aging, these are some of the markers of biological vascular aging. On the right, we have certain important parameters beyond blood pressure and lipid, which is called arterial stiffness. Pulse wave velocity and pulse pressure have received far more importance than a simple number of blood pressure. And early evidences of atherosclerosis in different vascular tree, which progresses at a different speed in different individuals. But this is something hidden which may start at the age of 30 or 40 in some people. And people land up with MI or sudden cardiac death in 50s, which remain curiosity for us, how these things progress. If I show you a single slide on vascular biology on hypertension from one of an elegant paper, if you read the lower bottom part on the left part of a slide, that how hypertension is dictated or is associated with something non-visible happening events on vascular remodeling, calcification, inflammation and endothelial dysfunction being part of it. And as you go upward, there are multiple pathways, not a single pathway, but multiple pathways apply to many patients and people. And there is a crosstalk between different pathways. It's not a single pathway which is responsible. So my simple question, as I and Dr. Pramila happen to be diabetologists, we know diabetes is so close to CAD risk equivalent, but is a single risk factor like blood pressure or an isolated cholesterol is a predictor of absolute risk? As you can see on the right part of a slide, depending upon the number of risk factors, it would still give you higher cardiovascular risk over a period of 10 years, 20 years, and if you project lifetime risk would be much higher. And as you reduce simply in pure hypertension with an antihypertensive treatment, if your absolute risk is higher, then the benefit and risk reduction is much higher. I suppose that most people in our country practice on simple numerical blood pressure measurement. 1/4 of our population has hypertension and remains relatively neglected, looking at a number of diabetes clinics happening in the country for 10% of population. We don't have dedicated hypertensive clinic where we need to look at ambulatory blood pressure and all kind of dipping phenomena and pulse pressure on finding an absolute risk in a hypertensive patient. But risk equations have become popular in a decade. Traditional risk factors are known to all of us. But what about newer risk factors? Ethnicity, unhealthy lifestyle of Indian patients, lack of exercise, air pollution, and sleep apnea associated with progressive obesity. So this and some of these newer risk factors applicable to Indian population would be discussed by Dr. J.P. Sahni. But going beyond that, whether it's a pure hypertension assessment, not in the global big trials, but in a routine standard private practice, real world scenario outside the trial would be discussed by Dr. Rahul Patil, who would also touch upon on how diabetes per se needs to be treated. So pure hypertension and pure diabetes, in combination, they make a deadly, but isolated also needs to be treated with statin or not, probably would be focused well in a given time, but other experts will contribute in discussion. Coming to a diabetology, if you look at vascular damage in red and in black, you will find microangiopathy or macroangiopathy, and you find that the damage anywhere and everywhere in diabetic population is a vascular damage. So culprit is LDL, which gets oxidized and creates a problem. Glucose gets glycated with all the proteins in the body, and a blood pressure contributing various kind of barotrauma with an underlying RAS activation and sympathetic nervous system activation. Inflammation and oxidant damage being not visible, we do measure HSCRP but I am not sure how do we react with hsCRP, and leave aside the growth factor which are responsible for progress in the vascular damage or cardiomyopathy, but this is under intense investigation in various tissues in relation to fibrosis-driven pathway. The last talk of the today would be decision to initiate statin therapy in primary prevention, and whether physicians and the doctors use kind of a scoring or not as recommended in guideline. There are patients' preferences and doctors' behavior in relation to the discussion with the patient. Statin compliance is close to 50%. So non-compliance is a big phenomena, whatever we may think of in terms of a benefit. So how a doctor behaves in selecting a drug and not treat the patient, again, a fault right at that level. But decision-making for a patient is an uncertainty. Patient will look for an alternative like a natural therapy or a lifestyle or a herbal medication. And adherence is a big issue with a long-term medication in a silent disorder. Non-adherence encompasses poor initiation, poor execution, omission of drug for many days, and poor persistence as a big issue. With this context setting, I would invite our first speaker today evening, Dr. J.P. Singh Sani, who is going to address on epidemiology of all risk factor in relation to cardiac disease in Indian population, where ethnicity, age, lifestyle, all would be addressed. Dr. Sani is a senior consultant and a chairman in Department of Cardiology at Sir Gangaram Hospital in New Delhi, member of multiple boards running right from research, ethics, and management, past chairman of Lipid Council, which is our subject in Crevast Academy during last 5 months, recipient of multiple national awards, member of multiple cardiology association across the world, and multiple book chapters and publication. So Dr. Sani, this is your topic on epidemiology of dyslipidemia, Indian perspective. You are going to share the slide. So I will stop sharing at this stage. Over to you, Dr. Sani. Dr. Sani, you are mute.
Yes, you can. Thank you, Dr. Sanjeev Shah, and thank you, Aris, for this invitation. So I thought that we will be discussing about the epidemiology, which has been assigned to me, epidemiology of dyslipidemia in India. Are we different? So for that, I thought that let me go through a recent publication. My voice is audible to you all?
Yes.
Yes, okay. So the
slide is moving or not? Slide is
yeah. Go ahead. Fine. As we all are aware of the fact that the cardiovascular disease remains the most common cause of mortality in our country now. And we have now seen that 60% of the people that die of non-communicable diseases in our country, out of which 50% are because of cardiovascular disease. And more than 25% of the mortality in our country is because of cardiovascular disease, which includes the coronary artery disease and stroke. And we have learned from the Interheart study and various other observation study that dyslipidemia is a key independent modifiable risk factor for cardiovascular disease. This is the topic which we have been discussing for the last 5 months. And compared to Western population, we get disease 10 years earlier. We have more risk factors. Probably we have also some genetic factors. So what we have learned that more than 50% of the people, they have coronary artery disease less than 50 years of age. and approximately 20 to 20% are less than 40 years of age. Now we started looking into the fact that why we are getting this disease in a younger age. Are we accumulating the risk factors of hypertension, diabetes, or we are also prone for metabolic syndrome like central obesity, much higher in our country compared to that of the global data, which was confirmed by the UK Biobank also. And we have also a peculiar problem of about chewing tobacco and BD smoking, which besides the cigarette smoking, which is quite prevalent, mainly so for the type B city and also in the rural area. So these are some of the risk factors probably which are important for our country. We are getting those risk factors probably in a younger age. And that leads to a type of atherogenic dyslipidemia, which has a high triglyceride, low HDL, and high small dense LDL particle. Then we started looking into the genetic causes which remain ignored in our country. We did a research on this for last 6 to 8 years, and because being able to utilize the genetic lab under Professor I.C. Verma in our hospital at Gangaram, we did a lot of genetic testings here. And then we started looking into the prevalence of familial hypercholesterolemia. We also started looking into the lipoprotein little a, although this was well known to all of us, but now there is a resurgence that this is an important neglected genetic factor, which we feel now that LPA is the most common genetic factor of dyslipidemia, followed by FH. Roughly 20% of the global population is suffering from high LPA, which is more than 50 milligram. In India, the prevalence is probably 25%. Similarly, for FH, we have found that the prevalence of FH in our country is again higher. We started looking into the sedentary lifestyle of our country for people, and they found the sedentary lifestyle is very high. We have unhealthy cooking, some dietary patterns. Vegetarianism probably also found to be slightly higher because we consume a lot of carbohydrate food, which may be related to atherogenic dyslipidemia. So all those factors which we analyze probably has caused coming little earlier in our country compared to the rest of the world. The importance is that because disease affects a working person, not a retired person as in the Western world. People are above 65 or 60 on average age, we are around 50 to 52. So that shows that there is a burden not only to the family, but to the society, but to the nation also. So with this background, we started looking into the prevalence of the data of the epidemiology of dyslipidemia of our country. So this is a good paper just published this year in Lancet, Mohan Group, and you all know about the very eminent endocrinologist, diabetologist. And this paper, along with his daughter, this shows the ICMR India Diabetic Study, which was it is a cross-sectional study on more than 113,000 individuals, of which 79,000 people are from rural area and 33,000 people are from the urban areas. Between the period of 2008 to 2020, here the dyslipidemia was diagnosed at that time with the NCEP panel 3 guidelines. LDL high was considered only if it is above 130, TG above 150, and HDL less than 40. So what we found overall, the prevalence of dyslipidemia in our country was more than 80%, which is very alarming. The low HDL cholesterol accounted for the most of the dyslipidemia burden, coming to approximately 67%. Both low HDL cholesterol and high triglycerides were uniformly prevalent across the country, whereas the LDL and total cholesterol did show some variation. Now this is the pictorial map, again showing same thing, that the high cholesterol levels showed a wide interstate and inter-regional variability, with the highest prevalence in the northern region, in Punjab, Haryana, Rajasthan, in Kerala, in Goa, and in the eastern part in West Bengal. The prevalence on the right, hypertriglyceridemia, the right side, you can see, is throughout the country, and it is seen high in all the regions of India, with very little urban and rural differences. So that shows there is a very high prevalence of hypertriglyceridemia. So similar was the picture of central obesity in our country. Then we started looking at the low HDL cholesterol, just like central obesity throughout the country. Again, we showed similar. It was high in all regions of India with very little urban and rural differences, whereas high LDL showed wide interstate and interregional variability, as we saw with total cholesterol, with highest prevalence in northern region, Kerala, Goa, and West Bengal. These are the areas where we have more coronary artery disease, where there is a high cholesterol levels. We look into the data, also the past data by Dr. Rajiv Gupta from Jaipur in his various studies done over last 20 to 25 years, Jaipur Heart Watch study. They look into the LDL above 100. They found approximately 50% of the population, both men and women, are having high LDL cholesterol. Since the non-HDL cholesterol was important because of atherogenic dyslipidemia, highly prevalent in our country, this data is limited to the urban middle-class population. And they did show that it is more, around 55%. So that shows in the nutshell that the prevalence of dyslipidemia is not low in our country, although we have a different type of dyslipidemia compared to the rest of the world. Then coming to our topic that even if we lower the cholesterol, LDL down, then we have still residual risk coming up. So we have to do something further more than that. So what is happening? So we started looking into the data of the 2019 ESC guidelines. They're divided into very high risk population of atherosclerotic cardiovascular disease, diabetes with more than 20 years of duration with multiple risk factors, CKD, familial hypercholesterolemia with atherosclerotic cardiovascular disease, suggested to keep it below 55. Whereas the high risk population was single risk factor of LDL more than 190, hypertension above 180, 100, and now we feel hypertension with end organ damage, diabetes with one risk factor, diabetes with 10 years duration, and CKD population, FH alone, whom we consider high risk population to keep the LDL below 70 milligram. But is it enough? What we have learned that we have used the statin, we have used the non-statin drugs, having known that statin or non-statin drug, whichever we use, if there is a reduction of LDL by 1 millimole, there is an equal reduction of cardiovascular events. So both of those are equally effective. So what we found that even in spite of reaching below 55, the residual risk was persisting, and that's how the role of PCSK9 came. And they have shown that we can go safely down below 40, 30, or even 20 milligram. The ACC expert consensus statement came a little later in 2022. They have also accepted what they were not initially the ACC guidelines targets, but now they have added that particularly it is more pertinent for our country, where there is an atherogenic dyslipidemia of high TG, low HDL, and small dense LDL. They have suggested that primary goal should be non-HDL if the triglyceride levels are above 150, because in LDL, we know the total LDL is the cholesterol, total atherogenic cholesterol, 90% is LDL, no doubt. But there is a good amount of non-remnant cholesterol, which is small ApoB48, the ideal VLDL cholesterol present in triglycerides, which are called together as a remnant cholesterol, should not be ignored because they are more atherogenic, although they are in small amount, but they are more atherogenic, should also be taken care of. And for that reason, they have suggested now that to keep the non-HDL cholesterol target equally good, because I have seen in my personal experience that many of my patients are below 55, but yet they are non-HDL, which should be only 30 milligram more than that. Instead of 85, it is well beyond that to even 100 milligram. And in that situation, now what we have learned is not only to give statin or non-statin drugs, we have to step up the drugs, add bempedoic acid or HMI to this population to bring down the non-HDL targets to below 85, which has been ignored and which is probably a medical, what we make an error in clinical practice when we do not look into the non-HDL, which should be taken care of because in our country, we have a different type of dyslipidemia. So with this, we started looking into the the genetic factor, which I have just shared, that as you rightly said, around 25 to 30% dyslipidemia probably may be genetic. And we used to think that familial hypercholesterolemia is a rare disease, and it is under-recognized, treated, no doubt, globally. But the last 1.5 to 2 decades of noise level of this entity by Dr. Kaushik Ray and his the global registry have shown that it's less than 1% of the globally, even in developed countries, the FH was diagnosed. Now it has increased around 10 to 15%, which is very important. So this was our first paper, which we published with young coronary artery disease using the Dutch lipid clinical network criteria. And we found that 15% of the patients, they are having familial hypercholesterolemia. This is a scoring system, very easy, just like the scoring for atrial fibrillation or childbirth score. So here, when we extended our study till last year now, that we have done now 1,200, now probably it is around 1,450 patients, we are finding that using the Dutch lipid network criteria, because we know that genetic testing is not easily available. So by phenotypic diagnosis, using the scoring system, 6 and above, what we call as potential FH, has been seen roughly touching almost now 16 to 17%, is not small number, a big number. So young coronary artery disease patient coming to us in clinical practice, and if you find there is no associated significant risk factor of smoking or diabetes, but has a significant increase in cholesterol level, always think that this is a patient who's suffering from familial hypercholesterolemia. The importance is that we are not treating the index case alone. We are treating a family. So that is the importance of familial hypercholesterolemia. So we should look for cascade screening of doing non-fasting lipid profile for their brother and sister and their children. If the level are above 135 for a child or above 160 for an adult, think that he is a carrier of genetic of familial hypercholesterolemia, and we should put them on lifestyle modification and statin, and to bring the levels to the desired level of less than 100 for adult, less than 130 for children, and probably will be able to save a lot patient in the society from premature cardiovascular disease, which is not very small number in our country. Then we're looking into the lipoprotein literature, which was an area which remain again neglected. Came in a big way with Dr. Anna's paper from USA, looking into the Asians settled in USA. But in between, for almost 2 decades, it remained in dormant state. But recently, now we have a good data to show that lipoprotein little a above 50 milligram, which is now is considered as an elevated LPA, has been found to be again high in our paper, which is the 1,000 patients, acute coronary syndrome patients with atherosclerotic cardiovascular disease. Looking into the high LPA, we found that it was higher in younger patients with MI compared to the elderly population. But the most important thing was, those who have got high LPA, there is increased severity of the disease. And we have a significant number of patients with familial hypercholesterolemia. And in them, what we found, they have high association of lipoprotein little a. So if a FH patient has high LPA, it is a double inherited condition which can accelerate the disease in such a magnitude we cannot imagine. And this is the truly extremely high group of population according to guidelines. One is the one which patient gets recurrent coronary artery disease within 2 years. Second is the one who gets coronary artery disease and now gets another territory, peripheral vascular disease or stroke. And the third one is the one, atherosclerotic cardiovascular disease, FH, and high LPA. So these are the extreme group population. Probably the guidelines suggest us now to bring it down to 40 milligram of LDL. And sometimes it becomes a challenge in clinical practice, even after using maximum oral drugs. Maybe you have to use the PCSK9 inhibitors. And in future, shortly we are getting inclisiran, probably that is a powerful drug which can be tolerated very well with this population. So up to my last part of my talk, that the response to statin, we have some data that the difference in PK/PD studies of statin in Asian population are slightly high, and we are more prone for side effects and also prone for new onset of diabetes in our population, even myalgia is there. Our own study, which is going on at the moment, what we got the interim analysis that in spite of giving high dose of statin, significant people, patient do not reach the goal. Even I've seen now with the high dose of statin and HTAV combination day one as an early combination treatment in ACS patient in our country, we found only 75 to 80% people reaching the goal of less than 55. So early combination of treatment for the management of dyslipidemia will be the way to go for to reduce the cholesterol level below LDL, and not only controlling the LDL, but also looking into the remnant cholesterol, which are present in high triglycerides. So I think I'll stop here and request Professor Sanjeev Shah to go ahead with the further.
Thank you, Dr. Sani, for highlighting the lipid level and lipid issues in our population. There is only one clarification I want for the people to note. LPA level, once estimated and found to be higher than 50, let's say in the range of 60 to 80, repeated measurement, untreated situation would still be similar, no? As I have learned that you don't need to keep repeating LPA for diagnosis. It remains high unless treated properly.
Yes, you're right, very right, that the LPA remain constant, so there's no need of repeating the test. As you rightly said, at least once should be done in lifetime of a patient. Unless and until patient has got CKD, patient has got thyroid diseases, probably they may vary, or during pregnancies it may change. So those are a rare situation. Otherwise, in general public, probably there is no need of repeating the LPA. And unfortunately, at the moment, we do not have any management, specific drug available to reduce the LPA level. The Pelacarsen drug, which is now being evaluated in Horizon trial, we are looking into that. We are participating in this. Probably next year we'll get the result, because it reduces LPA by 80%. PCSK9 inhibitor reduces by only 20 to 25%. They have not been given the label indication by guidelines to reduce the LPA. So for LPA, we have to aggressively manage the associated risk factor. It is an amplifier. If the two people are having LDL 100, the one who has got high LPA, then it will behave like 130. So that's what basically.
Probably we need to put a bold red mark on a patient case paper that this individual is high LPA.
Yes.
So that in repeated follow-up visits, we don't continue to look at LDL and relax. Probably some strategy we can think of, and we'll take up that later when Dr. Pramila finishes the talk. But to invite a comment on what you said, I would request Dr. Rahul Patil, but I would like to introduce him first as a consultant cardiologist at Ruby Hall Clinic since more than 20 years. He's been an associate professor at Sassoon General Hospital and BJ Medical College, Pune, had been a young interventional training received in Tokyo, Japan, Netherlands, fellowship at multiple bodies, and is a bright, best young interventional cardiologist. So Dr. Rahul, you will start your talk with a comment on what you listened from Dr. Sani, followed by your slides, and continue on that. What do you think about in the western part of India, unlike northern India, what his data showed? How do you feel regarding Indian ethnicity in west part of India? Dr. Patil, please.
Yes, sir. Thank you, sir. Thank you for the introduction. Great talk by Dr. JP. As usual, we always admire his talk. And sir, what I could learn from his talk is Western population, they do have low HDL and high TGs, but not as high as you see in the northern and southern part of our country. But when we see patients per se at our center, we have almost 3 cath labs, and we do around 600 plus procedures every month. So young patients coming to Ruby Hall has gone up, and probably as he has shown the new risk factors, as you also showed certain new risk factors like lifestyle, smoking, pollution, and these all factors are playing important role in young people. I think job stress also, inadequate sleep, too much of screen time. These all factors are adding on to the patient's risk for coronary artery disease and inflammation. And I think the time has come that we should treat Indians earlier than what Western literature says. As we get CAD at very early age, if patient has risk factors, you can even get ACS event by the age of 25 and 30s, which is not seen in most of the Western countries. Sir. So with this, I would like to start off my talk, role of statin in hypertension and diabetes. This is what, and so this talk has come with a recent paper which was published in last 2 months before at European Society of Cardiology. The paper comes from the Sweden group of authors, and what they are looking at is the effect of statin on mortality reduction and cardiovascular disease in patients with hypertension without CVD and diabetes. So we are looking at hypertensive patients without previous CVD or diabetes as a background. So this is what is a paper. Hypertension as an alone can cause atherosclerosis. This is a very good example which I would like to show you here. Young patients, coarctation is it's a congenital disorder, as we are aware, and most of the people, they get diagnosed at early age. And as we are aware that in the coarctation of aorta, this is a place where this is the proximal part of aorta, which is high pressure area, and this is a part with a low pressure area. Because of coarctation, there is a great pressure difference between these two segments. And this is a autopsy finding of this coarct patient, where at this coarct, before that you will see significant atherosclerosis. Beyond that, there is no atherosclerosis. So hypertension per se, whatever may be the age of a patient, it is going to cause atherosclerosis. There is no doubt about it. And I think it has to be treated similarly, because presence of high cholesterol, or even with the normal cholesterol values, a hypertensive patient can develop atherosclerosis. So this is a paper which talks about this use of statin as a primary prevention in hypertensive patients. So the objective of this study was to assess the effect of primary prevention, statin treatment, on mortality and cardiovascular death among individuals in primary health care with hypertension but without history of cardiovascular disease or diabetes. So this study was included male and female group of people, and the age group was around 60 plus. The LDL cholesterol was 4.6 millimoles, that is comes to around approximately 170 milligrams. 4.6 into 38 is a multiplication. 1 millimole is equal to 38 milligrams of LDL. And the study was done for the median follow-up for 4+ years. What they did was they evaluated 340,000 patients who have come to their clinic between the time frame of 2010 to 2016. And all these patients, they tried to scrutinize those patients who had CVD and diabetes, and they excluded from the trial. And remaining patients who were only hypertensive patients were divided into two groups of 13,000 plus each. And one group was given statin, other group was given just antihypertensives. And what they found, when the patient had the group showed that overall risk of all-cause mortality was 17% lower in statin group than in the control group. So here statin groups did benefited with this statin therapy from all-cause mortality, and the maximum benefit was seen by the time of 4 years, and this benefit continued as the patient prolonged the treatment. And during the first 4 years of follow-up of study, the mortality risk was 28% lower. When you talk about cardiovascular mortality here, the benefit was almost 20% lower in the first 4 years. And when patients were followed up for 8 years, the benefit of reduction in cardiovascular mortality was 15%. When you look at the treatment of statin with respect to male and female as differently, everywhere the females have got benefit of taking statin more than the male. So all-cause mortality here, again, women's have the hazard ratio is 0.77 compared to men. Where when you look at cardiovascular mortality, the women's have benefited more. Myocardial infarction, yes, women have benefited more. Stroke, again, females have benefited more. So when you talk about benefit of statin with respect to male or female, the females, they benefited more in hypertensive group of patients. So treatment with statins in primary care population with hypertensive individuals without CVD or diabetes was associated with decreased risk of all-cause mortality and CV mortality. Primary prevention with statins may be considered and offered more frequently and might warrant more prominent role in a doctor's toolbox. That's what it says. Along with this, blood pressure control remains the pivotal because you need to get blood pressure control. If the statins are given, that doesn't mean that your pressures doesn't come to normal. So you have to give good dose of statin along with good dose of antihypertensive to get the blood pressure values within normal limits. Now talking about diabetes and ADA guideline. So what does ADA says? ADA says there are three important variables which need to be looked into when you want to look for primary prevention in diabetes patients. So one is the age of a patient, the existence of previous cardiovascular event, and third is the presence or absence of risk factors. So what are the risk factors which have been considered by ADA? The risk factors are LDL cholesterol more than 100, high blood pressure, smoking, overweight or obesity, and family history of premature ASCVD. So statins for primary prevention. So when you look at a statin in diabetic patients, diabetes age between 20 to 40 with additional ASCVD risk factor, you can initiate statin therapy along with lifestyle modification. Patient between age 40 to 75 without ASCVD. So here there is no ASCVD risk factors and patient just has come with diabetes as a diagnosis. You have to use moderate intensity statin and get the LDL cholesterol less than 70, especially I would say in patients, Indian patients. But yes, less than 100 is also acceptable. So diabetes age between 40 to 75 with higher cardiovascular risk, including those with one or more ASCVD risk factors, here you need to initiate statin therapy, which has to be high intensity statin to target LDL less than 70 and or whatever may be the existing cholesterol is there, you need to get it to half, but better to reach to a goal less than 70. That's what it says. Diabetes age more than around between 40 to 75 with very extremely high risk patients with multiple ASCVD risk factors, those who have gone previous intervention and still getting repeated events. So these are the patients which are considered extremely high risk group. And in these patients, you should think of targeting LDL to less than 40. And in such cases, statins alone may not work in all the patients. There are 20 to 25% of patients who may require additional therapy in the form of ezetimibe, or those patients whose LDL cholesterols are really resistant for this therapy. You can add on PCSK9 to get, today bempedoic acid is also available to get this LDL cholesterol down. And if not, then statin therapy can be used. Now, this is the same thing. So almost all diabetes patients require statin therapy. That's what is my personal thought. Let's look at how the Indian doctors, they treat most of the diabetic patient. And this is one study which shows that statin use in men and women in Indian Heart Watch study. So when you look at these patients less than 40 years, only 34% of patients were given. And when you look at 60 plus age group of patients, only 62% of patients, they receive statin therapy. So in India, I think statin therapy is underused. But this is despite that we do get coronary artery disease at early age. So I would strongly recommend statin therapy for all diabetic patients, irrespective of their age, so that we should prolong their life, preventing their coronary artery disease. Thank you very much.
Thank you, Dr. Patil, for nicely summarizing a single paper in hypertensive population, as well as ADA recommendations in diabetic population. Your talk creates two important questions, and we have two experts, one cardiologist and one diabetologist. So we will have one question for cardiologist. What do you think, Dr. Sani, looking at the findings of this recent paper of pure hypertensive people, I am sure that there are some people who are at moderately higher risk and some people far more higher risk. So what are the risk markers in a hypertensive population in absence of diabetes? And your comment on specifically on LVH, albuminuria with hypertension, family history, and probably presence of NAFLD as a marker of CV risk in hypertensive people. How do we identify this population who must be treated with statin?
Thank you. Thank you very much. Very relevant question we have asked. I think so far, as Dr. Rahul said, that every diabetic patient will require statin. To me, looks like in future, the every hypertensive population will also require statin, because the reason is the common final pathway or is the pushing of LDL or non-HDL cholesterol into the wall of for the formation of atheroma. Who pushes? Hypertension, diabetes, smoking, and stress. They push, but the common denominator is LDL. So what I personally feel that the ESC guideline 2019 they put 180, 110 as a hypertension, which is as a high risk population, and to keep the LDL to below 70. And similarly, within one and a half year, the guidelines came on prevention of cardiovascular disease, and in that hypertension chapter, they have straightway written that hypertension patient with target organ damage, like you rightly said, the LVH, retinopathy, or microalbuminuria, which is not that uncommon, the ACR high levels. These are the group of people, they should have LDL cholesterol below 70, not below 100 for the general population. So they have straightway said that. So they are again categorized into a high risk population. So I think I'm very happy that we got this paper, which has given similar type of result, just like HOPE-3 trial. Again, showing that alone treating hypertension is not that important unless and until you tackle simultaneously the lipids also. And bringing it below 70 probably is the way what we have learned for diabetes for majority of the patient. Now, the only standalone patient, young patient with BP 140, 100, probably we say keeping below 100 may be good. Going below 70 may not be enough evidence at the moment, but yes, high risk population of hypertension with very high level of hypertension and patients, those who have got target organ damage, one should try to keep LDL below 70.
Thank you, Dr. JP. We selected this paper because this was not a clinical trial. This was a real primary care practice setting, real world observation for a long period of time. And Sweden is a country where we have excellent records and investigations which throw the highlight on how the disease would behave. Presuming that even hypertension is well under control, still there is a high risk. Shifting to a question for Dr. Pramila, kindly unmute Pramila for yourself.
Yeah.
What Dr. Rahul has shown regarding ADA recommendations and all prevention strategy, looking at various risk factors, the behavior of diabetes practitioners. You know, in our country, everybody is a diabetologist with huge burden. What do you think? Why people, how much they use statin, why they are not using statin as what is necessary? And your final comment at the end would be on new 2023 ADA guidelines for an LDL target, which is different from all these past papers. Dr. Pramila.
Yeah, good evening, everyone. And thanks, Dr. Sanjeev, for the question. So when we are talking about preventive strategies, we know that when we put the patients on statins, like as endocrinologists, obviously all the patients who are above the age of 40 and they have type 2, they have to be on statins mandatorily. But below the age of 40 also, we have to do a ASCVD risk scoring. And most of the patients who come to us as a tertiary care center will either have other comorbidities like smoking, or they may be hypertensive, they are obese, or they have a family history of premature heart disease. These are all the patients who come into the high risk category, and they also need to be put on statins. The most important thing which we find in our practice is most of the patients may be put on statins, but they may not continue that. because patients don't have this information that they need to continue. They think that their LDL was high, or sometimes they are put on fibrates also for triglycerides, and the LDL, particularly when we are targeting, we know that their LDL is high. They are put on statins. They see a normal LDL, which they classify as normal. We don't know we don't say that is normal, but we say it is controlled. But what the patient will do, they'll stop the medications after that. So this is a usual thing which we see, and we clearly know that a patient who is on statins, and once they stop the statin, their risk of an unstable plaque is even higher, and they can actually get an event. So that's one of the things. And we hardly see patients who are more than even 40 who universally require statin are put on statins. If they are type 2, I'm talking about a type 2 diabetes scenario. Coming to the ADA 2023 guidelines, it has given us clarity that we obviously have to give statins to all our type 2 diabetes who are more than the age of 40. As I said, less than the age of 40, also the intermediate and the high risk categories will definitely require statin. And we also have to be aware about the dose of statin. What we see in our practice, the patients don't take the correct dose. So they are on a very minuscule placebo sort of a dose. They'll be on atorvastatin 5 mg or maybe rosuvastatin 5 mg, which is not the recommended dose for a patient who is diabetic and above the age of 40 or is in an intermediate or a high risk category. Also, we know that with the latest ADA 2023 guidelines, it has also clearly showed that previously, above the age of 75, we were not even talking about statins in a normal type 2 diabetes. But now they clearly say that that is also a group which is to be considered to be started on statin in case they haven't been on statin before that. So that's another category of patients which now we have more clarity on, because previously we were just labeling them as more than 75 and leaving them out. So that's another thing which is there in the newer ADA 2023 guidelines.
Thank you, Dr. Pramila. We move on to the next talk of Dr. Pramila Kalra, who is professor and head of endocrinology in Ramaiah Medical College and Hospital in the city of Bangalore. She is a young gold medalist in various fields, honors in MBBS and MD medicine, various publications and more than 25 chapters in different books. Is a good speaker and academic practitioner. Would throw a highlight on something different paper, which is more in relation to the behavior of a patient and behavior of a general practitioner and physician. This is relevant because Dr. Sani and Dr. Patil would see the patients when event has already happened. They are more in tertiary care hospital, managing more secondary prevention, while we diabetologists have primary responsibility of primary prevention, and we have to prevent the first event. Let's read summary from your paper we have selected for you. Over to you, Dr. Pramila.
Yeah, thanks, Dr. Sanjeev, for the kind introduction. And I'll be just sharing my slides. I think my slides are visible. I'll just make them full screen. I think they are visible now, right?
Right.
So it's a very, very nice paper, and though it was published way back in 2011, but it is a very, very interesting paper. As now we had discussion that any patient who comes to the cardiologist, we know that they mostly all had an event. There are hardly any patients who go firsthand, because most of the times if they have some symptoms, then they'll go. There will be patients who won't have the disease or won't have the event, and then still they will go for a cardio health check. But that percentage is a little bit lower, though now people are becoming more aware. But as endocrinologists, our primary responsibility is to see for the prevention. And the major problem which we face in our patients is a cardiovascular event. And we know that our type 2 diabetes patients, or if they are type 1 also, they are all prone for cardiovascular events much earlier, 10 years earlier than the normal population. And now we are seeing more and more patients with type 2 diabetes coming to us at a very early age. So we are seeing youngsters, and by the time they are 35, 40, they already had diabetes for around 10 to 15 years. So they all come in the high risk category. So one of the things which we always have, or we have a problem in our practice, is explaining the patients about the need of the statins or the need of the preventive medications, because we know that when the patient comes to us for treatment of diabetes, they expect us to write 1 or 2 drugs for the treatment of diabetes. But when we start talking about statins or cardiovascular prevention, or we start talking about other prevention also, even talking about foot care, even talking about the care of the kidneys, that becomes a problem, because that point of time the patient starts or asks us that what is the rationality for that and how much is going to be the prevention. So this was a very nice paper, and this was one of the books which I was once reading. Like this is this, we know that this book this is an older book, but it has also nicely talked about how different ethnicities may respond differently to preventive medicine, because many a times you may see that some group of patients and sometimes also rural and urban, you will see the difference. And sometimes in India, we have so many states and we see the difference in different states also. Like I have practiced in Lucknow also, and I've practiced in Bangalore. So I have like North and South, both exposure. So I know that how the patients respond differently to the way we tell them about preventive medicine, and how we have to differently approach the different types of patients. So this was one of the articles which was published, where they tried to see the patient and the general practitioner attitudes to taking the medication to prevent the cardiovascular disease after they have received a detailed information on the risk and benefits of treatment. Now, this is very important for our setups, because we get all sorts of patients. We may get a patient who is very literate, who has read it a lot and might be so-called literate, but may not be knowing exactly the medical things, but might have read Google. There's a patient who is actually literate and who understands what you say and has a trust on you, full trust on you. And there is a patient who has no trust on the doctor and will always go for doctor shopping, because they will think that whatever you are telling, you're trying to unnecessarily add the medicines. So this was like, we know that patients most of the times do not always choose to accept the preventive medicines, because many times their questions are, why should I take it, or what is my need to take it? So this was the study which was done to identify and explore the attitudes of patients and the general practitioners towards the medicines, preventive medicines for cardiovascular disease after they have received the information. So most of the times when we start statins for all our patients who are, as I told you, above 40 for all type 2, we need to give statins. And when we talk to them about preventive medicine, the first question about statins is the statin going to damage my liver, or am I going to be addicted to it? The similar thing happens when we try to convince them for insulin or even for anti-diabetic drugs per se. So we know that research towards the patients and the health professionals' attitudes for the medication for primary prevention is not too much. And we know that patient may be called as informed, the doctor may be giving the right information, but patient might ask for more information or may not be convinced with the information the doctor has given. So they were trying to see the general practitioners' practice, and they took patients aged 35 to 74 with without cardiovascular disease and who were not taking preventive med treatments. They were identified, and letters were sent to highest risk patients. They were invited to attend the practice for coronary risk screening and to participate in the study. And they wanted to explore that patient's attitude towards taking medicine overall, and also specifically in relation to the cardiovascular disease prevention. So now if you see, whenever we talk about even diabetes, forget about only cardiovascular. Like if a patient walks into our OPD and patient has a HbA1c of suppose 10, the first thing the patient will talk to you, will listen to you, will talk to you about diet, will understand everything. And you write the whole prescription. At the end of the prescription, the patient says, doctor, can I wait for 3 months and try? So this is the first thing we get. So similar thing happens for cardiovascular disease prevention. They will say, no, I'll do my lifestyle, I'll follow healthy diet, and I'll see, and let me try that, and then I will see. I'll bring my LDL levels down. They'll see the LDL and they'll say, no, I'll bring it down. I'll bring my triglycerides down. I'll increase my HDL. And sometimes we know that patients want to go for natural approaches. They say, we'll do self-healing, we'll go to some center and we'll try and we'll get okay. And many detox procedures and many things they'll try to do. This is a usual tendency, especially in our country. And they want to keep medication to a minimum, because this is a tendency all over, that patients think that if they take more medications, they may get more harm, or their liver or kidney may be damaged, which is a common tendency or common misconception amongst our diabetic patients, common myth which we always face. And they say, and also not only concerning cardiovascular, but also when we try to convince a patient for taking insulin, they will try to remember somebody in the family who would have had kidney disease and would have been put on insulin, and then the patient might have not lived long, and they will think that this is a life-threatening thing. And they will attribute the deaths to the insulin and not to the uncontrolled glucose values. And also this addiction word is commonly used by the patient. They will be addicted with smoking, they'll be addicted to alcohol, but they will say that we will get addicted to medicine. So that they will not stop, they will be okay with those addictions, but the medicine addiction is the thing which they are all worried about. and the side effects of medicines. So let us see how the different patients in this study responded to. So this was one of the patients who was an Asian Indian male who was age 64, had a 15% risk. So he said, yeah, the doctor is doing his job and we don't know how to cure it. So the doctor definitely knows better. So if he says, take these tablets, I should take it. So this is a patient who is a good patient for you, who will agree and who will rely and who will trust you. This is a trust patient who's trusting the doctor. These patient number is a little bit less because nowadays doctors do give the right advice to the patient as always, but many a times the patients don't directly trust. So this is another lady who is a white Irish female and she is 72. Her risk is 7%. Again, she also thinks that the doctor should make the decision and they know what is best for me. Again, this is a old person who was working in a factory, and he is a white Irish male. He is 68. His risk is 11%. And he also feels that I should go with the doctor at all times, but I'm not very much impressed with the graphs and the figures. So this patient has a little bit of a dilemma in the mind. Now, this is a typical patient whom we see in our setup. So this is a clothing wholesaler running own business. He's an Asian Indian, 48. His risk is 2%. And the doctor said that there'll be a prevention for him, but he said that chances of coming better, like doctor said that you better have this thing because chances of coming out are 6%. It is a very small percentage. So this patient is not very much satisfied. And this is one Asian male doctor who is a GP. And he says we should always recommend preventive medication to the patients. So he says, I don't take the slightest risk with someone else's life. So there are different ways. We've seen how human nature is. Like some patients may trust you. And if you try to see or try to think about in the last 1 week, whatever patients we would have seen in our OPD and would have prescribed them statins for cardiovascular prevention, how the patients would have responded. So one patient would say, yeah, I'm okay with what the doctor says. The other patient would have some trust. The third patient may not trust you at all. And there will be patients who may show that they trust you, but they won't trust you. That patient is not there here. But we know those patients exist. So they will say that I trust the doctor, and they will say on your face that, doctor, I'll do whatever you say. And they will come and tell you I've taken the medications, but the family member or the wife will tell you that the patient hasn't touched anything what you gave. So these are another group of patients who will look like that they are trusting, but they'll never trust. They'll never follow what you say. Now, there are another type of a GP who is, we treat patients more medically than we treat ourselves. So pain and disability would need to be there before I would take drugs. So this is a patient doctor who feels that I should not be too much overzealous with the preventive medications, who thinks that there has to be some problem, then I should talk about more of medication addition for my patients. So if you see, the major concerns were what? The major concerns among the patients were medication could be addictive. This is pan world, you can say, not only pan India. So patients think that they get addicted to medicine, and if then they cannot live without medicine. And there may be some unknown side effects which are not known, which the doctor is not able to know at the moment and may come up in near future, which is always possible. It's not that we can negate this fact, but we have to always tell the patient that whenever we are using medications for you, the benefits should outweigh the risks. This is how we have to tell them, because these type of questions will always come up. And whenever we are trying to convince our patients to take preventive medicines, we always have to tell them the reasons why we are giving it, why the cardiovascular disease is more in patients with diabetes, and if it happens, how much is the mortality increase, how many years of their lives are cut short if they develop a cardiovascular problems. And that is why we are giving them, and not only the years of life, but it's also the quality of life and the productive years of lives, which are cut short when they get a cardiovascular problems at an early age and even at a later age as well. So we know that there is a concern in decision-making around starting the preventive medications. It's a good idea to talk about it at every visit and allay the anxiety of the patient. And we know that always this communication between the doctor and the patient is not very effective. Sometimes the patient may be happy and may understand. Sometimes the patient may show that they have understood but might not follow. And we saw in this study that even if the information was presented, there was still some confusion between the preventive and the curative. So patients may not understand the concept. A lot of times in our OPD setups, we'll tell our patients that you have to take statin. The patient will say, for your prevention. Now, patient will say, I never had a heart problem. My father had, and he is taking statins, but I never had a heart problem. Why should I take? So they have to understand the difference between the preventive and the curative. You have to tell them your father had a cardiac event. That's why he is on a higher dose of statin. You are taking it for prevention. You'll be on a lower dose of statin. I always tell my patients, like, you take vaccines. You take COVID vaccine, you take pneumonia vaccine, you take influenza vaccine. This is like a vaccine for you. You take vaccines to prevent the disease. You don't wait for the disease to come. Similarly, this is a vaccine. This is a typical thing I always tell my patients, because this is how sometimes they understand, because they understand, yeah, okay, a vaccine like of a thing it is. So then they will ask, vaccine has to be taken only once. Why should I take it every day? So I'll tell them this vaccine is a daily vaccine. So this is how we can somehow make our own ways to convince. And we have to see that it has to be on a case-to-case basis. So no patient is same. So some patients may want a different set of ways to tell. Some patients may want a little bit of a threatening way to tell, you know, you may land up with a cardiovascular problem in another 2 years. So you definitely need it. Or we have to also tell them that why it is being started for you. We have to explain them. And it has always to be a shared decision making. Then only the things will work in the right direction. So with that,
thank you, Dr. Pramila. Will request you to stop sharing. I have last 6 minutes and 3 rapid fire questions for all 3 experts. Starting with Dr. Rahul, what do you think is your experience with urban patient and rural patient in Pune in relation to subset of your practice in which it is not secondary prevention? Primary prevention, it could be diabetes, lipid, hypertension, but prescribing statin for something called a silent disease.
Right.
Urban versus rural. Pune is also a high-tech city.
Yes.
I would request you to add at the end of the first question, what do you think till the last decade we had Dr. Google, who gave multiple choice and an access
That
to
came in
right
my
and
mind.
wrong information. Your future generation is going to be ChatGPT,
Yes.
which is curated content, probably presented more sensibly. I am not sure how it would evolve with
Right.
competing companies. So
Yes.
you have 2 questions.
Yes, sir. Thank you very much. Sir, actually, the way you asked me, first question came to my mind was Google. So whether it's urban population or rural population, with the availability of 4G and smartphones to each and everyone today. But more so in urban population, we see this problem very frequently. Even the rarest of the rarest side effect of any drug, they can talk to you and discuss with you at stage that how this has happened to me. So that's the biggest problem today we are facing. Whenever we try to give a medication which will help to prevent their future event, there is always a thought from a patient side that in long term this is going to adversely affect him with some side effect. I do think this is going to be a problem in future more also because of, as you said, ChatGPT is going to be more frequently checked by patients and their relatives to discuss or to further evaluate doctor how good he is in the treatment. This is going to be a big challenge for next generation doctors and even next generation clinicians, where people will be definitely giving them options for the treatment, what possible treatments could be possible in such patient. You know, maybe it may be dyslipidemia or hypertension or diabetes, and they can give you options that this could be a better option in this patient compared to the other one. Vis-a-vis when you talk about rural population, I think the compliance of rural people is far better than urban today. Urban people, they do not understand that screen doesn't give you knowledge, it is just information, and you have to inculcate that into a knowledge, and which is possible only when you rigorously study that subject for a long time. And that's what they forget, that information is not a knowledge, and they try to teach the person who is knowledgeable. But that's not true with the rural population. Rural population, I feel they are more complacent and compliance to the medicines than the urban population. Over to you, sir.
Dr. Patil, it was true. Dr. Pramila's paper was a Birmingham-based UK studies. which has the UK has a mixed population, and lower educated people had higher compliance than in higher educated. Doctors are less compliant, engineers are less compliant, business people may be marginally less compliant, but we would leave that subject there. We have two more rapid fire questions. Dr. Sani, JP, you are there. I have a very important question. I can't see JP on screen.
JP sir has left, sir.
Yeah, so we'll come to that after Pramila answers. Pramila, the communication skill when it comes to preventive therapy needs the skill, needs the time, and needs the language which patient understands. So there are 1,000 internal medicine practitioners. What do you think you would like to give them a message in relation to skill, time, and language for a preventive therapy like statin?
It's a very pertinent question and a very important question. So when you talk about communication, it has to be obviously in the language which the patient is comfortable with. Because if you try to communicate in the language which the patient is not comfortable with, it sometimes becomes very difficult. Now, in a city like Bangalore, where we have multilingual population. So what we have to do is obviously the local language or English, Hindi, Kannada, that all is feasible for all the doctors. But many a times we do get patients who are not understanding any of these three and they will understand some other. So in such situations, I think it's always your team. Like you will have people in your team who will be speaking different languages and you should always take them along. Obviously, we have to be a part of it, but those people will also be helping you to communicate. So communication is the most important. Over and above that, we should also understand that we have to give time. Because many times patients have lots of apprehensions. And if you give them time and sort out those apprehensions, I think it makes a huge difference. So whenever you are trying to communicate or tell something to the patient, be it a preventive medicine, be it the medicine you are trying to give or the curative medicine, you have to give ample time. You have to communicate in the language the patient is comfortable with. You have to tell them and allay their anxiety. They might have come with thousands of questions from wherever, maybe Google, Chat, GPT, whatever it is. We have to tell them the answers, because if we start scolding them, then they will not be able to understand and they'll never comply. So I think these two factors are the most important, and it has to be a shared decision making. At the end of the day, no matter whatever we feel is needed for the patient, it has to be a shared decision making. And that is how the patient is definitely going to benefit if we do that shared decision.
Thank you, Dr. Pramila. So Rahul, I have the last question.
Yes, sir.
And Aries team is also listening, partly on a science, partly on the society, and partly for pharma. This was for Dr. JP, who is not here. So you too can think about. So I am putting certain facts. I have read an elegant paper of Kaushik Ray in relation to lifetime LDL exposure and population health, which calculating the compliance says that statin reduces only 23% risk, including Mendelian studies and all of them. If you look at PCSK9 could be closer to 50%, and maybe future vaccine and all future drug would still keep a burden of CAD alive. With this kind of a progress in lipid and newer drugs, the whole population has remained far behind in their belief, and nobody has done anything on changing the understanding of statin or a lipid science. We keep on lowering the limit from 70 to 50, and maybe, as one of you spoke, on a 40. People have remained behind. What do we do about those people who are so behind when science has progressed so much?
It's very important and pertinent question, sir.
Yeah, we are not policy maker. Maybe Delhi speaker was closer to.
I think the key opinion leaders across medical society, some leaders from the political background, some from the bureaucrat background, has to come up, and it should be part of now school curriculum, that what is better for the longevity of. And unless and until we do that, primordial prevention, I think that will play a important role. As you rightly said, we are trying to treat it, the problem. We are not trying to prevent it. And prevention, I feel your question always will be remained alive, I think, till the time some key opinion leaders take this to the extent that it has to be implemented in day-to-day life.
Thank you, Dr. Patil. Do you sounded similar to what we endo feel about obesity and nutrition to be taught right at school and college level in order to prevent future epidemic?
Right.
The last point, Dr. Kalra Aris is also listening. Over last 15 years, it applies to you also, Dr. Rahul. Over 15 years, what kind of pharma-generated literature which educates the patient on lipid or a statin you have seen, which does the best job? If it doesn't exist today, we might request an Aris team to come out as part of a Crevast campaign, as I run Crevast Academy, which is all science-based, not marketing-based, but these are marketing and medical affair people in Aris might think of. In your last 15 years, which pharma has generated best lipid and statin-related education material? Handed over to the patient, starting with Dr. Pramila and then Dr. Patil.
I think obviously the greatest evidence is obviously from the RCTs and the long-term cardiovascular data studies which have come up. So I would not say that any pharma company, it is basically more of the drugs which have been studied, the innovator drugs. So most of the we have so much of the trials with Jupiter, like Jupiter trial for rosuvastatin, and we have many more trials with that, and we have so many trials with atorvastatin. So it's all the data, but what pharma can generate is more of a real world evidence about compliance and the reasons for non-compliance. That would be more helpful, because the evidence to say that the statins are beneficial for cardiovascular disease prevention, there is no controversy. We haven't had any controversy on that. But what data we need to generate is what is the extent of the compliance, because the problem which comes up, the patients don't get the correct dose. That is one problem. The patients will take a placebo dose. Second thing, they don't comply. So this is the data which has to be generated, and the reasons for non-compliance, which can give some insights for the clinicians to chalk out better strategies to communicate the benefits of statins better to their patient, because the patient listens to only the doctor. They don't see the real world evidence study or the PubMed studies or anything. What the doctor says is what the patient wants to, patient will understand better. And the doctor has to be convinced that the data is, ample data is available. And most of us are knowing that the statins being the key preventive strategy for cardiovascular disease, we have no controversy. We have ample data from RCTs, from meta-analysis, from real-world evidence, from follow-up studies. So we have data. But the compliance and the reasons for non-compliance and how to make it better what can pharma companies can work.
So Dr. Rahul, Dr. Kalra has answered half of the question in relation to convincing the doctor and studying the reason. My question to you is pharma-generated patient education material which could change the patient's perception. Have you seen? Statin is the most important part of your practice.
No, I haven't. But yes, pharma, what they are trying to do, especially when we talk about Iris, as at our clinic level, what we do is, along with patients, whatever the relatives they come up, pharma is supporting them to get a free lipid profile check. So they understand that, yes, these are the free blood pressure check, sugar check. These are things which are happening at the clinical level. But when you talk about mass population level, no, I don't think anyone is doing right at this moment to aware people about the major risk factors for CAD. What I would suggest is, in long term, as US has put on whatever food you are eating, the calories in it, the cholesterol value of it, those things, probably the coming generation will be more into the values, what calories it has, what type of cholesterol it has. And this type of probably education to kids with respect to food, what they are going to eat, will help them to prevent intake of food which has bad cholesterol or maybe very high calories.
So Rahul, 100% of population is so difficult to influence. So yes, presuming that 20% of clinic visiting people need a statin, so probably Khushbu last week only has come out with one of her statin molecule, a patient education material and a story and a tinkle and kind of a stuff, with one of her statin molecule, which probably is trying to influence the patient that why do I need a statin? Those who need the statin. So probably Aries is trying to target exactly those people who need and who must take, that their compliance improves. With these remarks, I would end myself here. If any of you have any last comment to say, last words, you are welcome.
Thank you, Iris, and thank you, Shah sir, for wonderful moderation. And thank you, my co-speakers, to be part of this program. Thank you. Good night.
Thanks, everyone. And thanks, Dr. Shah. It was excellent moderation and we had a nice discussion.
Over to you, Kushma.
So thank you very much to all the expert speakers and moderator for the thought-provoking session today. Definitely, after today's talk, a thought has to be given on prevention of CVD, even if the LDL is low, but the risk is high. And very heartily thanks to all the delegates for joining with us today, taking time out. And next month, on the same model, right, second week of the Saturday, we will come back with the next session of Crevast Academy. Thank you very much. Thanks.
Thank
Good
you all.
Good night.
Good night. Thank you.